All right.
Yeah, I don't remember who it was, but it was this. Did we contact the person that published on the Our Future? Yeah, UK Biobank or MOB
Mm-hmm.
paper. Did we contact the person, or maybe I was supposed to do it?
Yeah, I think you volunteered.
Okay, so I
Yeah.
haven't done that. Okay, so
Okay.
I'll do that. Okay,
Okay, great.
thank you.
Yeah. And Brandy, was there anyone on your list?
I did. I had emailed one of the data model contacts from the Nutrition Precision Health Initiative under
Mhm.
the Common Fund. I copied you. I didn't hear back. I can send
Okay.
another ping. They did have some shifts around on that program. So if she's still not the right person, maybe she can direct us to somebody who is.
Okay, terrific. Thank you. All right. And so with that, we will get today's speaker. Hayden Spence is going to share, as it says, an overview of patient-generated health data. Hayden, I can stop sharing and you can take over and share your slides?
Yeah, sounds good.
Perfect. Thank you.
So the way I generally do this is I write out a presentation in Quarto. I don't know if anybody's used that. It's a R, similar to R Markdown. And then after I do this, I have a kind of resource PDF that I can just switch over, and that has a bit more information. So I will send that out. I usually base that a bit on some Q&A. So I can make sure those things are relevant. That'll have a lot more of the information on the specifics, but for now, we'll just kind of go over the overview. My name is Hayden Spence. I am a consultant primarily in healthcare research with the federal government. So I have to add my big disclaimer here that I am not representing anything related to the federal government or clients, people that have hired me to work on this stuff. This is purely just my own involvement with Odyssey here. And I didn't want to specifically focus on any federal departments, but I've worked with HHS, the VA, and the DoD. So we'll kind of do a little brief overview of those and some of the healthcare surveys they have. I would say that encompasses most of what the U.S. Government's healthcare survey landscape is. There's not a lot of departments outside of those three, but I've worked with most of the departments. So the one I will say that might not be included here is Department of Commerce and some of the internal things when it comes to looking at healthcare economics. Or sorry, not commerce. Anyway, you get what I mean. The more economic side of things is not looked at as much here. So should have switched this slide earlier, but mainly looking at healthcare surveys at the population level. So I know last time we discussed a bit about the difference between assessments, evaluations. This is purely population level surveys that are usually either administered in the clinic or by mail or another route. So nothing that is no assessments like the I've worked with a lot of mental health assessments, but for some reason keep getting bundled in the surveys. Nothing clinical here. So this data is primarily used for public health decisions and a lot of program evaluation. I would say, honestly, I see a lot of policy being made from survey data, sometimes more so than any clinical data, although that has different routes in. I would say it gets filtered more with subject matter experts into a larger policy discussion. But when it comes to people at CMS or the VA making decisions around broad kind of resource allocations, healthcare surveys have a big impact with that. So in terms of supporting research, I think that's a big area for improvement, is kind of mixing the two and doing it side by side. Usually you would have the subject matter expert clinician presenting kind of the research clinical data stuff, and then you would have an entirely different meeting or discussion around some of the healthcare survey results. So I'd love to see more inclusion of both. Same. So the VA, there are two very large healthcare surveys. This is not all of them, but these are, I would say, the two most prominent that you'll see: patient satisfaction with VA services, and then a more broader demographics, health status, and service usage. The second one, the National Survey of Veterans, is used because not all veterans will use VA healthcare. Some don't qualify, some may qualify for some services. It's kind of a mix, and I've seen this used a lot for usage, right? How well is outreach? Are there like big service gaps where, for whatever reason, veterans are qualifying? They do have access, or not access, but they do have VA healthcare, but they're not using it. So what is that for? So there's a lot of things that this captures. It's also the big one for employment. So when you look at unemployment among veterans, this is kind of the main one there. SHEP is used quite a bit for looking at the satisfaction with VA services. It's become very, I've not seen an effort within the VA that doesn't include this to some degree if they're working with patients. And less so in maybe like the direct research, but I really only think that's because it's not as clean as other clinical data to include. And we'll get to some of why that is, but any effort I've seen with allocating healthcare resources or clinical like programmatic initiatives, SHEP is almost always used to gauge and to understand how it's being received. So out of the two of these, I honestly, I could see SHEP being used for research if there was more, for example, like OMOP was mapped and there was a very clear way to use it. It is used for research, I should say, but not to the degree I think it would be if it was like interoperable. Over at HHS, the first one I'm not as familiar with. I looked up a bit on it, and honestly, it feels a little bit older in terms of insurance coverage, but it does seem like the main way that insurance coverage is looked at within kind of the non-VA, non-DoD, the civilian population. And it also looks at chronic conditions. So this would be where the data from the CARES and the public health insurance options would come through this, but it's not the only source of it. And it's not the only source of chronic conditions, but this one I think is done by mail. The one that I'm more familiar with, and I did a lot of my research actually in grad school on it because it's so accessible, and I think would be a great one that maybe even this group could get some partial access to. I'm blanking on how difficult that was when I was in grad school, but it's not. I think it could be a feasible one to start working with in some ways to maybe do like a direct case study. This is a the behavioral risk factor surveillance system. So it's mainly administered to teens and young adults. And it looks at things like smoking, alcohol use, exercise. A lot of states participate in it. We'll focus more on it in a second. But it is it's a fairly large. If you're looking at like SDOH factors, this is a good one to look into. Some other ones, you have some Medicaid, Medicare surveys. When we get into HHS, it's a bit more disjointed than you see at the DoD or VA, just because it is not as, I mean, it's not a singular healthcare system. So you have a bit more of a divergence, and you have a lot of these are starting to be collected more by mail than rather like in clinics or things like that. Although the Medicaid, Medicare stuff is a little bit more direct because some of that can be required for payment. The medical expenditure panel survey, this is a little bit more into healthcare economics. And HRQ is also really good for patient safety and some other measures under HHS that when we look at surveys, they combine a lot of patient experience just with the patient safety measures as well, which have a pretty high correlation. Like it turns out, I felt this doctor listened to me, correlates with good care all the time. There is a similar health behavior risk factor kind of survey in the DoD. It might surprise a lot of people to learn that the same population that we look at, college age students, teenagers even, actually a big population in the DoD as well. The same pretty similar age group. So that is something that's it's also collected, and it's very similar to the nationwide one for health related behaviors. It's a little bit more broader. It's not going to ask service members, certain things that are more relevant to high schoolers. But the age demographic is actually pretty young. So the college age one is almost sometimes very similar questions. A lot more family-based stuff as well, though. Health information, National Trend Survey. This one is geared towards clinicians or hospitals and looking at specifically sorry, this is a different one that I'm thinking of. I'm going to skip this one because I'm not sure. There's one that's about electronic health records, and that's clinician focused. And there's another one that is focused on how people use Fitbit or those types of devices, or will use Google to look up their symptoms, those types of things. So I want to be sure that I have that right. But I'll make sure that the follow-up resource document has that distinguished. So, like I said, the interviews, surveys, mail, sometimes in person. I would say less so. That's the case, but sometimes you'll have it in the clinic. Yeah, that way more with unified healthcare systems like under the VA or DoD. Pretty randomly sampled. I think it is very selective for most of them because they will do random sampling, but for example, the behavioral risk behavior survey that is usually administered in high schools, sometimes college, the way it is administered depends on the state. So the state has to opt in, and some will opt in some years and some will other years. And it's a frustrating component of that survey. The analysis is, I think survey data is the hardest thing to analyze sometimes because it does not have a very straight, they all have very good, and I'll share in the chat here, tools to look at survey data like dashboards. And I would say the methodologies in there are what folks will generally want to go with, because when you get to the raw data, say you got CMS permission or something like that to access the data itself, it can be fairly messy. And if someone isn't experienced with the analytical methods, it's really easy to slip up because it's not as, I mean, I shouldn't say it's not as straightforward as biomedical data. It's just very different. So going between those domains, I think, is a hard thing to do. I like the fact that in general, because of the way this data is collected, they can do public dashboards, and there's some really good examples of that. Response rate could be better for most of these for any survey data, but in terms of the federal healthcare survey landscape, it's gotten, you can look at a trend and it slopes downward, unfortunately. I think there is going to be a big need for collecting some of this more electronically, and that has been worked on to a large degree, but people just don't, they won't respond to it, especially if they won't respond to it if it's, I'm not going to look at a piece of mail. It's just not happening. But if I got a text or something, maybe, I don't know. So I think that the actual capture for some of these is a challenge. And the way it's ported around could be better. I remember receiving just zip files of Excel. The data infrastructure in the Fed has come a long way in the past 3 or 4 years, I would say, with not using just Excel files or having APIs sometimes even. So the reliability of some of these federal healthcare surveys, the raw data, has changed. But again, I remember not even 7 years ago or so getting just Excel files in a zip file that was like, version 5 from my PI. And I don't really know how much that differed from the email he got from CMS. So but some of them, like the VA SHEPS data, you can tie right into the VA's API, which is amazing. And if you are writing analysis code, you can just ping that with your API key. That's a much more reliable way to do it than to give people kind of flat files. The biggest thing with survey data, and I think the problem that this group will encounter the most, is that survey data is almost always, I shouldn't say often, it's almost always not linked to preserve privacy. So if you were looking at within subjects or even between subjects, it becomes a problem. It's very different from the data we have. Usually in research, the way I see it being used is, well, I'll give an example. I was looking at infectious disease rates for some rare diseases, and they wanted a denominator. So we looked at the NSV, and it's just not really clear. Like we couldn't, it became a huge challenge to try and work this data. We had to get into probably a different, we had to really look at some other techniques because it wasn't the right denominator. It's the best way to get demographics for that population. But when they're not all using the healthcare service, so we don't know if they had that infectious disease or not. And also, it doesn't map directly. So we don't know if we're double counting a lot of things. So mixing some of this is not really possible, and it'll be interesting to see how you all try and overcome that, because often it's just used as fodder for the abstract sort of thing.
Oh, so Hayden, do you mind if I ask a question during?
Yes, I'll say for now, let's just open it up for questions. I have two of these case studies, the ones I know the most, and we can look more at one of them, and I'll try and use those to answer questions.
Yeah, no, going through this case study is fine. I didn't mean to interrupt your flow. I was just trying to make sure I kind of understood some of the challenges. So I definitely know the joy of inheriting an Excel file that was not necessarily filled out with the idea that this is data that's going to be analyzed. But it also sounded like you're saying one of the challenges is, even though like a lot of these assessments are repetitive, that it's really hard to link the same person across different times they've taken the survey. Was I understanding that correctly?
Yeah, so panel data is kind of what that is referred to as. And if you have repeated measures of the same person with every year or so, it is present with some of the surveys and some of them not, right? For example, SHEPS at the VA, this Veterans Experience survey, from my understanding again, I might not have seen, there might be something out there where you can do this, but from the raw data that I've seen, every time it's submitted, you would have for that iteration an identifier for the person, but not necessarily the next time it's administered. So it's anonymized and not linked. Now, I would not be surprised if something so central like the VA's healthcare system, you might have that potential to link between the times that a person's taken it and do something with that and have actual panel data. But the youth behavioral risk factor survey, no, I'm almost confident that doesn't exist. It might exist at a different level. You definitely could look at it state level. That's going to be hard because there's sometimes states don't do it that year for some reason. Some of them have chronically not done it. Speaking of chronic health conditions, not taking healthcare surveys at a state level, I would argue, is one of them. But you have different response rates for each. Maybe look at the states. Under states is going to be, there are like site levels or county levels. That's going to be even harder because the dropout rate. So I think it depends on the survey system. Now, what is way harder, and I would only maybe see with a something like the SHEP, is linking patients, their healthcare data, and their healthcare survey. That is probably something that even with this, even if there was a way to track year after year someone's response to that, I would doubt that there would, I'm almost sure that there is a policy of it being anonymous and it not being able to be linked like that. So even there's some others that do work with like patient safety. I work a lot with an all-employee satisfaction. That one for sure can't be linked. So that's another thing that'll come up is any large survey of this type. I have not seen, at least in the US, the allowance of linking it to patient healthcare data. Not that that wouldn't exist, just that like it would not on any circumstance be allowed. You might even have systems that make sure it can't even ever happen. But yeah, that's what I would say.
Okay, yeah, thanks for explaining that. Yeah, so it sounds like a lot of these are basically a population level assessment and not meant for following individuals over time, but rather the population.
Yes, and I might have focused on what I am understanding as survey more than on the forums I was having a discussion with Christian about assessments and how that differs as well. To me, this is healthcare surveys, but again, we might be entering a domain, and maybe that's something we figure out with this group of what are the types and what does that mean. Yes, these are all population level for the most part.
Yeah, and I think that's helpful to know the types, but I'm guessing, and it's been great to hear your perspective because a lot of the members of this group are dealing with cohort surveys. So it's nice to see some of the other use cases that are out there. And it makes sense that we, want to, maybe add something to the types of question we're asking about sort of the level of the survey. But I'm also guessing whether it's a panel or survey or some things you and Christian were talking about, they're still having the same types of challenges in OMOP where it's just not as readily usable with things outside of EHR or claims data.
Right. So both of these SHEP and Bureau FSS I have seen used in tandem with not exactly OMOP, but that clinical level data. It's just used differently, right? So like it's used with comparing, for example, if you had certain rates of alcoholism in a state, and you wanted to either use it as a preface and a context within the clinical trial or whatever study was being done with the clinical level data. This would sometimes be used against, because you can get very good like demographic level estimates. You can, it's probably one of the more reliable ways to say, okay, well, here's a health disparity, and we don't see that maybe with this cohort or with this this healthcare system or something like that. Maybe I want to claim that like my healthcare system in the state has, controlling for income level, controlling for all those things. People that have this certain insurance have better outcomes when it comes to health behavior risk factors. But those are particular to this research. And I think it could be used with OMOP just because of how wide some of these surveys cover. It's fairly likely if we have a network study that's somewhat US based, you could have coverage for that. But how that links, rather than just, oh, you would just go access it on your own, is kind of another question. Like I could think of times when it would be useful to have the SHEP in like an OMOP form, but I don't know. Again, it would, that overcoming that linking element. I'm almost thinking it would look something like, on the person ID level, this person possibly could have taken this survey, like they would have been within that cohort, and not necessarily a direct link of we have this social security number, we have this, because that often is not even there. But the potential of that person having been in that surveyed demographic, I think could be a useful way to tie things in, almost maybe a different ID of like a survey ID or a.
Well, it can also give you some information about your source population. I think one of the challenges in survey work is, are you getting a sample that's representative of the area that you're sampling. And so I could definitely see using this data with EHR data in the sense of, okay, if this is my sample population, how well are they being represented in the EHR data, or maybe in another, person-based survey that's also taken that level or in that area. So I could see where it would be, aside from the reasons it was developed and already used, I could also see applications like that.
Yeah, going through this, I thought a bit about, how would that be linked in a non-direct way? And I mean, it could be worthwhile just exploring that type of, does this survey, this population level survey, fit into the study cohort? And like you said, to what degree can we understand if this is a representative sample of that group? Also comparing SDOH, I think it's a big one. Like we do a lot of work in the NLP group with SDOH and collecting a lot of health factors. I was going to present more on health factors because that is the more granular side of things. I am not able to myself, but I might be able to convince someone to, just because at that more granular level, it is basically the government has to say, go ahead. And I'd probably have to get somebody, a federal employee to do it, or at least their office to write off on it. But comparing the health factors that we get from NLP and that we collect in that more granular sense to the representative kind of survey filled out health factors would be interesting, because some of these are collecting, smoking status or things like that. And to be able to say, okay, well, we did this for every high schooler in Maryland. Now we're going to look at what we collected on an NLP level with, John Hopkins or some other kind of larger system in Medicaid, maybe even. How are we doing with the NLP system? Can we validate that? I think that could be an interesting avenue as well. Anybody else have other questions? I will send, again, I kind of just wrap this up into a PDF, which will have some of the slides, but I put more resources on it and links. So if you have any questions about some of the stuff, I can make sure to tailor it a bit to that.
Thanks, Hayden. And I do have one more question, and who knows, maybe this is a question that'll end up on the survey, but if you could, I don't know, wave a magic wand and get exactly what you needed to help, map this data across these different population surveys or to OMOP, what is the thing you would like the survey group or Odyssey or whatever to provide to you? Like what's the thing you think would improve your life most relative to OMOP and Odyssey and working with these data?
Yeah, I think some sort of algorithm or indicator of it, if you could look at, I mean, it depends on how much patient history we have, but I'll use this Maryland example again of, if I'm looking at a bunch of Maryland high schoolers and I have maybe a clinical health data for one mapped into OMOP, I want to be able to see, if that person ID, would they have been in this survey collection or this year, or which years would they have been in? That way, I think some statistics could be done that way, because it's not just you're adding something additional and not just saying, who knows, people can move. Sometimes we don't have patient history of where they live. That's a whole different ball game. People move way too much.
Yeah.
If they could just stay in one spot sometimes. But it might work better with the more healthcare healthcare system specific one, or like CMS, things like that. But basically, you know, if this person's 50 and I'm not looking at anything where they would have been surveyed for this ever in their life, or at least I don't have the years for those surveys that they would have been a candidate to take it, I'd like to know that, because you could exclude people that survey is with a pretty high confidence not representative of, and not trying to like figure out who took the survey or not, but more of how well does this survey represent that person ID based on their profile, age, all those things. Because if you looked at like, it would be a very poor representation of, you know, for a research paper, if you were taking this survey and including it in your paper, and then you had a cohort of people that, I mean, for example, weren't even US based. There's no way they could have taken this survey, and you didn't have any indicator of that. Well, you're using what is a pretty large population level survey, but there's no reason why it would represent, you know, the Canadian cohort that has been included in this. That there needs to be some sort of an indicator there. And I think that would allow a lot more clinicians to use some of this in a more nuanced and less just like, here's my introduction portion, or just as fodder kind of. I see that a lot where I used to work a lot with violence. Actually, I didn't put this on here, but I don't think the National Violent Death Review System really applies. I used to work with that healthcare system a lot, or that collection of data, and people would just put, if you look at, you do like a literature search, almost every abstract, it just starts off with like, there's such and such many, you know, homicides in the country or something like that, and these are not useful statistics. So a much more nuanced way to use some of this stuff specific to the target demographic would be, I think, a good direction.
Yeah, thanks, Hayden. Anybody have any other questions or anything this makes you think about, oh yeah, maybe we should discuss this? So the purposes of having Hayden, another speaker, basically to share, it's part of our landscape assessment to kind of share what the challenges people are having, working with surveys so that we can kind of prioritize the work of this group. So if there's anything that Hayden said that rings a bell or makes you think of another question you have, feel free to share. And then if not, we can maybe hop over to the survey, which is another way we want to collect some of this information and kind of go through some of the questions and see if there are any other elements we should be collecting and talk about that. All right, well, thanks for sharing, Hayden, and I appreciate you sharing the documents. Getting the wiki set up is still on my list of things to do, but that's where we'll put slides from speakers as well as the recordings and minutes for these talks. So let me go ahead and share.
One thing I'd like to just add really quick, just as kind of a takeaway, is I think survey data is extremely important because of how much it impacts policy decisions. So the work of this group, writing all this out made me really realize how the past projects I've worked on some of these surveys with went on to make hugely impactful changes in healthcare systems. So the more we can get OMOP and real world evidence linked up with survey data, the better, because it has this unique direct line into policy that some other types of data don't as much.
That's a very good point. Thank you. Okay, so that brings us back to our trying to develop the survey. One of the things I was thinking is that for defining what's considered a survey, we've talked about these different ones. I'm wondering if we can just say any tool used to collect self-reported health information. And that might be like a good generic definition, because I don't think we want to exclude based on if it's individual level or if it's a questionnaire versus a panel versus some other survey. And a lot of times these things are used interchangeably. So I propose that these are basically in the order we thought of things last time we met. So not in particular order, but again, this is kind of information we want to collect from the Odyssey population, to get information about the surveys they're working on and what challenges they're having with those surveys. So, and I can kind of slowly scroll. So anything we want to add? I think you brought up a good one to add to about the survey. Like, is it population or individual level? I'm just going to pop that in there.
I'd also mention with, this is coming from kind of my discussion with Christian a bit, it's different if a clinician is administering it. So when I think of assessments, there's like Berg balance scale, which like a physical therapist might do, the Montreal cognitive assessment, which you're going to have a psychologist administer, or a psychiatrist administer. And these aren't surveys, right? Like they get lumped in for some reason, but they are what I would call like assessments. Yeah. And we can look at maybe SNOMED and we can get into like the types and things like that, but you're gonna have a lot of people that might come with, and unfortunately it's more common with the mental health space for whatever reason, but they won't consider it as like an assessment of the neurological system. They'll consider it like, oh, you surveyed this person. Well, no, you didn't survey them. This was an instrument that was administered. So assessment is something we'll have to probably maybe even explicitly ask for, or have some sort of a way to make sure people aren't lumping it in with like what people fill out in the waiting room.
So I guess I think that possibly what I'm dealing with could be useful on the survey as well. Can I share and maybe that might be helpful?
Sure. Yeah, can stop sharing.
Oh, not my screen, just my predicament, I guess.
Oh, sure.
Yeah.
I'll go back.
So I have worked with OMOP data in N3C, the National COVID Cohort Collaborative data portal of patient EHR it was like from 70 different sites across the US. It was all harmonized together. And I saw how incredibly useful that was to have all of those different sites and be able to analyze things across those across those different sites and all those patients. I'm just trying to figure out if something like that is possible with survey data, or if there's not really a way to make it quite that interoperable, because like some of the issues that I saw on the forums is like, you might have two different questions and two different surveys that are kind of asked in ways that are not compatible, or it's held in the observation table, and so some of the standard tools wouldn't necessarily capture that, like Atlas and things like that you might not necessarily be able to build a cohort in a similar way as you would with EHR. So I'm even trying to figure out what the advantages of converting to OMOP R, and if it can be made to be interoperable and be able to use different surveys together, you know, through OMOP to actually come to conclusions, or if it's easier just to use the raw survey data and do it that way, if you're basically just potentially just representing the questions in a different standard. Does that make sense?
Yeah, it makes sense. And I think that is ultimately our goal, right? So the benefits are interoperability, or what you said you saw with those sites that were able to do the interoperability surveys. It just allows you to increase the size of your data pool. And, you know, if, like, for example, you know, there are a lot of survey, like one of the things we're going to be talking about, trying to assess from the information we're gathering, or what are the most, you know, common data elements that are used across surveys, and can we at least harmonize those? You think of the, you know, age, race ethnicity questions, sex gender questions, a lot of things like that are collected in a lot of surveys. So can we harmonize, you know, start harmonizing across those? But, you know, one of the things I think that's, at least for me, really amazing about OMOP is that, you know, 12% of the world population has at least some of their data mapped to OMOP. And so that's a tremendous sample size, and also demographics for when you're trying to do health assessments and do, you know, policy decisions and things like that. So the ultimate goal is to make surveys as interoperable as possible. But you're right, it's a challenge trying to use, you know, tables that were set up for EHR data and those methodologies and apply them to a survey. And so that's what we're trying to do. Like, what gaps, you know, sort of what gaps can we fill in for what already exists and make the process easier, and then ultimately build things out that are specific for harmonizing surveys. And then, of course, you know, when survey data is also mapped OMOP, it makes it easier to use with EHR data. So that if you're looking at patient reported versus EHR records, you know, you have the ability to do some validating or fill in details that aren't in the medical records. You know, there's some things that I think you mentioned, I think Hayden mentioned smoking. There's some things that are notoriously hard to get from EHR data. So the survey data can be supplemental too. So yeah, it's definitely a goal and the purpose of the group, but we've got a ways to go to get there. But you know, trying to do these one-off, you know, trying to create a sort of a Rosetta Stone, you know, system for mapping is definitely more productive use than doing all these one-off mappings that we typically stuck doing when we want to combine survey data from two or more programs. And so, okay, I want to work with generations, I'll do this mapping. And then, now I want to work with our future health. And then you do a separate mapping. And whereas if they're mapped to OMOP, then you're just harmonizing across those. And then that harmonization is good for other people, so it's not thanks, Bunsey. So it's not it basically makes it more useful. Like, we all agree mapping and harmonizing is hard, but if we can all map to a common standard, then at least it's a one and done. You do it and then you're mapped to everybody else who's done it.
I do agree with Brandon's. I was just going to say, I do agree with Brandon's point though about, just the actual way that those questions are asked, because if the source material isn't standardized, then there's nothing standard to map to. And I was just thinking about, the BRFSS, and that to me is a great example of something that was, if that was in OMOP, that's something that's cited and repurposed across so many different studies, that would be something that people could map to. I think it's figuring out like those key elements, or, select variables that are reused or repurposed from really well-established studies. That could be helpful. I was also just thinking about these details we have on the screen. And I think that's really another great opportunity, Nicole, with the OMOP survey conduct table, where it's a lot of metadata about the surveys. And I think that's something that we could help to standardize, is for those researchers who want to do research on survey design. I don't think that's been tapped into all that much.
Oh, that's cool. Yeah, I hadn't thought about that, but that's exactly what we're collecting. So yeah, that would be a cool use of this information. I like that. Cool. Well, we've only got a couple minutes left, so I usually like to try to end with action items or next steps. So I saw, Brandy, that you sent the email that there's a response. I didn't get a chance to look at it, but thank you. And then Monse also sent her request during this call. So it sounds like we'll be able to get some additional use cases and experience on our calls. And then I think if you haven't had a chance already, this is in this week's agenda, as well as I think in the minutes from last week, but take a look at some of the content. Is there anything else we could be asking? Didn't really flesh out this triumphs and challenges section, but that might be helpful. And then I think between now, we're going to actually have a 3-week gap between meetings, since we're going to do Oleg's talk on the 29th. So if between now and, maybe like 2 weeks, you could give some feedback or add, some additional questions. And then, so you and I will work on trying to format this into more of an actual questionnaire looking format that we can take another look at and discuss how we might want to administer it and collect the data. So one of the things I was thinking about is we have a survey tool that we developed for Connect called Quest that is a free source, and also has a pretty nice back end as far as analyzing the data goes, and that might be something we could use for it. But I'm also open to suggestions. So Hayden, thank you for presenting and sharing the work you're doing with your surveys. Brandon and Julia, welcome. I hope we continue to see you at these meetings. And everybody have a great rest of your day. Bye.
Are there any resources that I can access that you guys might have? Or
right now, it's mostly now that you're in the meeting chat, you ought to be able to see the recordings and transcripts from other meetings.
Okay.
I can also send you our past minutes. Like I said, the goal is to get these up on our wiki, but we just don't have it set up yet. So it's on the list of things to do, and then they'll be all in one place. But that's basically, and then for our mission statement and like objectives for the year, those can all be found on the work group page. If you go to the survey subgroup link, and you actually, for some reason on my computer, it doesn't land exactly there. I have to scroll up a little bit, but you'll see a picture of me, and it'll have the presentation of the mission statement objectives and then the slides as well. So if you want to get
I saw that one.
Little better idea what we're trying to do this year.
Okay, I'm not sure if I'm on the team. Would you be able to double check? Because it wasn't on the form to request that form where you say I want to join this group, this group, this group.
Yeah.
This group wasn't on there, so I'm not sure.
Okay, I was wondering about that because I had not been getting any of the forms, so I'll ask Craig about that.
It's not on there.
I was worrying about that because I was like, oh, I'm not seeing any form, like, because I know that's how people join, and then you get added to the mailing list and that whole thing. And so I'll ask Craig about making sure we're on that list. But in the meantime, I've got your name and Julia's, and I can add you to the list and add you to the invite.
Okay, perfect. Thank you.
All right, great. Thanks.
Thanks, Nicole.
Bye.